The ascending limb and the descending limb of the QRS complex is slurred or is showing luxuriously going down slowly, which goes in favor of VT, whereas in SVT, this initial limb is sharply coming down and the distal limb is slow, which goes in favor of SVT. Same thing happens in AVR, which helps in diagnosis. Vericke criteria has got higher specificity and sensitivity and negative predictive value. Here is a diagnosis of of ST segment elevation in AVRT, which shows ST elevation in AVR. Tricyclic antidepressant is a leading cause of death in states where increased heart rate, widened QRS and prolonged QT go in favor of forthcoming seizures and arrhythmias. The same thing in AVR, ST elevation in AVR as well as QR in AVR goes in favor of higher rates. It helps also in Brugada syndrome to diagnose. This is called QR in AVR, which is known as AVR sign in Brugada syndrome. So ultimately, to end, let me summarize that it helps to identify and risk stratify left main coronary artery or proximal LAD occlusion. It also helps to diagnose acute pericarditis. It can differentiate between VT and SVT. The behavior of AVR also can differentiate AVNRT versus AVRT, Brugada syndrome, and all of you know dextrocardia. If there is a positive P wave in AVR, then it favors the diagnosis of dextrocardia or at least technical dextrocardia and TCA poisoning. So ultimately, I would like to say in conclusion that AVR was a forgotten lead, but not now. AVR was an orphan lead, but not now onwards. AVR was redundant, but not hereafter. Prudence lies in looking at 12-lead ECG as a 12-lead ECG only and not as an 11-lead ECG. My acknowledgements are due to AICPL Dantoli, Avanti Heart Clinic and Vocard Heart Hospital for their generosity in contributing ECGs, and also to Dr. Uday Mahurkar and Prashant Jagtap for their generous intellectual help. Thank you so much.
Sir has highlighted many features and diagnostic and prognostic importance of the lead AVR for, in ECG. If there are any questions from audience, please.
Thank you, sir, for a very nice, extensive presentation on AVR lead. It's also commonly used when a staff nurse or a junior doctor takes an ECG and there's a wrong placement of leads. So AVR is commonly you can pick up as a wrong leads placement. AVR lead is also very useful if your patient is unstable hemodynamically and patient is in shock and presents to you. Always think of a left main or triple vessel disease, and better you shift patient for early invasive therapy, because anybody who's in cardiac shock with 7 leads ST depression, AVR elevation, there's a 80 to 90% mortality. But if you do an invasive angiogram and if you do some revascularization, this 90% can be reduced to 40%. So instead of doing medical management in ICU, more aggressive invasive therapy is more useful.
What is the significance of AV ST elevation while doing TMT?
Can you again?
If we get depression during TMT in AVR, is there any significance?
While doing TMT?
Yeah.
Yes, it is significant. It indicates the involvement of the left main coronary artery disease. If you are getting ST variations in the AVR, similar as you get in the CCG.
Thank you.
Thank you very much.
It may be very rare in TMT you have changes only in AVR. It may be very rare. When you have changes in other leads along with AVR, then most of that's a common scenario. So then you say that's for that.
But let me emphasize, we are not looking at AVR alone. We are looking at all the precordial leads, all the leads. AVR is one addition to our armamentarium while diagnosing left main disease or proximal LAD disease.
I request Dr. Harish Bajaj sir and Dr. Mahajan sir to felicitate Dr. Suryavanshi sir with momentum. I request Dr. Karya sir to felicitate Dr. Bajaj sir and Dr. Mahajan sir.
Respected delegates, it's a pleasure announcing the Mrs. Asha Vasalwar Best Free Paper Award to Dr. Dipti Deshmukh. I request Dr. B.D. Wagh, sir, to kindly present the award. I request Dr. Dipti Deshmukh to please be on this stage. Dr. Dipti Deshmukh has presented paper on study of acute kidney injury in ICU. She has won the second prize for the Best Free Paper Award.
Next is Symposium on Syncope. For that, I would like to request Dr. Uday Mahurkar sir, Dr. P. Karandikar sir, and Dr. Tankiwale sir. Sorry, it's Purnima Karandikar ma'am, Dr. Uday Mahurkar sir, Dr. Purnima Karandikar ma'am, and Dr. Tankiwale sir.
Respected organizers, my colleagues, friends, practitioners, and the students, on behalf of we all three, we thank you for inviting us for this particular panel discussion, and we'll try to make it as useful as well as interactive as possible for all of us. I am Dr. S.R. Tankiwale, working as Professor of Medicine at Jawaharlal Nehru Medical College, Sawangi Meghe. Plus, I am also working as Director for the Center for Health Professionals Education and Research. This particular center is a newly established center in a University of Datta Institute of Medical Sciences, and it caters with all the educational needs of the students of all the colleges. But I am a very small man. Along with me, I have got two giants with me, and I don't know how can I survive with them. One of the giant is Dr. Uday Mahurkar, who is known to everybody as a national and international figure. He has extensively worked on the syncope for last 17 years, and I think his experiences are much more valued for us than the experiences of an internist. The second panelist is Dr. Purnima Karandikar. She also is a specialist in neurology. She also has worked extensively in neurology and has got a special interest in syncope. And I'm sure that selection of Madam also is the right choice for making this particular symposium or the panel discussion as the one of the best possible thing. Now, what we plan in this particular panel discussion is that we'll first give a short introductory remarks and lectures for about 30 to 45 minutes. And after 45 minutes of discussion by all three of us, then we'll start discussing the questions which we receive from the audience. For this particular purpose, I request all the respected persons in the audience to pass on their questions on a piece of paper to the organizer or to us, and we'll select and we'll try to answer most of them over a period of time. So that is what is the rough plan of this particular panel discussion. Now, why syncope? Why this particular topic has been chosen for the panel discussion? It's because syncope occurs in many normal individuals. It may just come and pass off once in lifetime, or it may just come without being noticed by most of the individuals, or it may come with a very dreadful type of the experience that a particular patient gets during the particular attack. The syncope that we think today, or syncope that we think is probably a benign one, probably might be dangerous, and some of these syncope may be life-threatening. Patient may even die after a severe attack of syncope. So it has got a very wide range of the manifestations in a given practice, and therefore the syncope is a very important part that needs to be discussed. It has got dramatic presentations in most of the cases, or contrary to it, it may be symptom for which a particular patient may not be prepared to. He suddenly falls because of that particular episode. Even the relatives may not be prepared for that, and that may bring panic to the most of the patient as well as the family members. Unfortunately, syncope does not fall in anyone's category. It is neither a physician's category, nor a neurologist category, nor a cardiologist, and nor a particular specific person's category. Most of these patients, they go to neurophysicians, whereas there are very few conditions where really a neurophysician can intervene in the cases of syncope. Cardiac physicians is always important because the cardiac causes, whenever are there, they are always dangerous but need to be taken care of very, very carefully in these particular patients. Some of these patients also land in the ENT specialist and they manage this patient, ultimately refer this patient to either physician or to cardiologist. So it's really a no man's domain where you can really investigate this particular symptom complex. It's a very, very important disease because of the fact that some syncopal patients may have a very fatal outcome. More so when it is of cardiac origin, and it has been shown in this particular slide that the cardiac causes of syncope have a highest mortality rate and as compared to the non-cardiac causes for the syncope. What is the impact? Why this particular syncope needs to be understood in a better way than otherwise is that it has been shown in various studies that the syncope can lead to anxiety and depression in as many as 73% of the patients. So one syncopal attack in lifetime, the patient may become depressed, may be anxious, may not be able to go for the particular job again for a very long period of time. It may alter daily activities. So even if a particular person gets a syncope, he will be always afraid of going for the activity more confidently or more surely. And therefore syncope and its cause needs to be understood very carefully. It will also cause restricted driving, and it is